All right, thanks, David. Good morning, everyone. My name is Boris. So what I've got for you is just some cases that hopefully are all very familiar to you, and we'll use this as a platform to discuss perhaps some the updated guidelines in the European Society that you may or may not have seen. So I'm just going to start off with defining syncope, and just a reminder, it's a transient loss of consciousness due to cerebral hypoperfusion, and it's characterized by a rapid onset, usually, a short duration, and spontaneous complete recovery. So in my first case, I have a 73-year-old male that I recently saw, and he gave me a story of when he was descending stairs, he suddenly felt weak in his legs, and then he had this unusual sensation of a whooshing noise in his ears. And he was able to break his fall to the ground without loss of consciousness on the first episode, but he had recurrent episodes frequently when he was bending down or when he was standing up. Neither of these episodes were associated with palpitations, chest discomfort or breathlessness, and over the years he has had fatigue and breathlessness when walking inclines, but these hadn't been really progressive over the last 12 months. His past medical history is significant. There is ischemic heart disease, and although he doesn't get angina pectoris now, he does have a history of coronary artery bypass grafting, and then 4 years ago having right coronary artery stenting because the internal mammary artery graft to that vessel had been occluded. He has comorbidities with treated hypertension and dyslipidemia. In his ECG, we have here, it's not quite sinus rhythm. He has bigeminal rhythm with a supraventricular ectopic beat, and his baseline is a left bundle branch block. And that had been known about really since his 2014 occlusion of the right internal mammary artery graft. He had an echocardiogram under my care, and that showed evidence of prior myocardial infarction with regional wall motion abnormalities, and it would be concordant with what is seen in the right coronary artery. He had normal left ventricular ejection fraction overall, as was his right ventricle, and there were no significant valve lesions, including the absence of aortic stenosis. On an event monitor, he had this, and you will see at the left here, he has a native cardiac beat, and then a supraventricular ectopic beat following that, and then after that, he really has sinus pauses, and on this occasion, it lasted 8.3 seconds and was associated with his symptoms of what I described as pre-syncope. And so the diagnosis there was sinus pauses, and the treatment there was a permanent pacemaker. Before going to the next case, it's a pretty straightforward case, but I'd be happy to take any questions about that particular case. It was a pertinent story to me because there were some aspects about that care that made me think it was cardiac, but what really perhaps swayed me to a possible vasodepressor component was it always happened quite consistently when you're standing up or bending down. But it was the abrupt onset and his feeling weak that I proceeded on to investigation for structural heart disease, especially with his history of ischemic heart disease, and therefore chasing a bradyarrhythmia.
So would some people pass out with that as opposed to just feel like?
Yeah, it just depends on the duration, I suppose, and certainly their threshold to symptoms is determined by both output or vasodilatation. So if someone does have valvular disease, or does someone have poor ejection fraction, they could have a lower threshold for tolerating the sinus pause duration. Okay, so in my next case, we have a 19-year-old with recurrent syncope who had it really since 15 years old. And she describes her symptoms as quite stereotypical. It's a premonitory symptom of reduced hearing sensation, and then a feeling of nausea, and then what she described as black vision. This was followed by lightheadedness, and then invariably collapse with loss of consciousness if she was unable to lie down quickly. It was very common when she was standing from the bed in the morning, or in hot weather, sitting under a hot hair dryer, or during times of increased psychological stress. And when I saw her, the symptoms were very frequent, twice weekly, but even up to a daily occurrence. The family history includes congenital deafness and unfortunately mother also being deaf due to rubella. Her examination was relatively unremarkable. The pulse was regular, was good volume, and even on a supine blood pressure, there was initial difficulty getting a blood pressure, I suspect because it was very, very low. She would have premonitory symptoms of feeling faint, and then the blood pressure I would then record at 100/68. So A4, what was important there was to see the correlation with symptoms. And this was her ECG, again showing sinus rhythm. We see a normal cardiac axis. We have a supraventricular ectopic beat that you see in the middle of the rhythm lead at the bottom, but otherwise just non-specific T-wave flattening in lead V2, and everything else was unremarkable. And the diagnosis there was vasovagal syncope, and many of you would recognize the symptom description. And often it will be explained to patients that it's just simple fainting, you can go away, it's unlikely to occur again. But I just wish to highlight this case because it's a case that I have not seen as severe again, but it was so severe that for this particular patient it was associated with loss of employment because of the frequent pre-syncope. There was a social isolation because she was too scared to go out, and there was a delayed achievement of adult milestones because she didn't socialize, she missed some school, couldn't pursue her dream of becoming a model. There was a car accident involved. She's had falls down the stairs, and just in 1 year, she had 14 hospitalizations. So to call it simple fainting does not really do that diagnosis justice. I had her on treatment, and many of you would know, increased salt intake, increased fluid intake, midodrine and fludrocortisone to try to augment the central circulating stroke volume. But it doesn't always work, and because of the persistence of symptoms on this occasion, the historical aspects didn't lead me to question my diagnosis, but what I wanted to do was to understand how the mechanism of treatment that I had to date had failed. So I supervised a tilt table test, and hopefully you can see that at the back. It's not the true recordings that I have seen, but I've really highlighted the blood pressure and then the red dots that you can see in the back as to what happens after her tilt. So what you can observe is that initially when we stand her up, the blood pressure seems to rise appropriately, and then with her in absolute vasomotor without stimulation, we see that there's a gradual fall in her blood pressure, the lowest recording 90/50 before she had syncope, and that was actually associated with a syncopal seizure. And correlating with that gradual fall in blood pressure, there's a gradual rise in her heart rate, and that really achieved almost about 140 beats a minute associated with that hypotension and symptoms, and this was on treatment. So in addition to other therapeutic strategies other than an increased salt and water intake, then I think what things are important to explain the diagnosis to the patient, provide some reassurance, an explanation of the risk for recurrence, getting them to recognize those early symptoms. It's not always, though, that they have enough warning from their premonitory symptoms where they can either sit or lie down. They should certainly discontinue any offending medications, not relevant to our case. And again, trying to recognize those prodromal symptoms to either sit down, lie down, or to do some particular maneuvers, which are physical counter-pressure maneuvers, to try to augment the vasomotor tone. On this occasion, it didn't really help the patient because the premonitory symptoms were so short. Drugs that can be tried are listed there, but to be honest with you, there really isn't a lot of evidence that a particular group is superior to others. And so I think I try to say to the patient that the majority of the benefit is not from drugs, And it's really about the lifestyle changes rather than relying on drugs as we often do for other conditions. Cardiac pacing probably has a small role. There is tilt training, and more recently I've learned about exercise training using a Texas protocol that I've brought back with me. Here are some of the physical counter-pressure maneuvers with a leg crossing with a buttock and thigh tensing. So the right leg on this patient is squeezed backwards and the left leg then providing the resistance to try to augment the vasomotor tone to shift the venous pooled blood back to central circulation. And likewise, stimulation from isometric forearm grip. So on this occasion, the new guidelines recognize this as a mechanism of reflex syncope. You may be more familiar with it as vasovagal. And there's many things that are very typical, and in this particular case, I've highlighted them in bold. There is a long history of recurrent syncope for 4 years. There was an unpleasant sound, and there was unusual susceptibility to a boiling kettle, for example, that seemed to stimulate these symptoms. There was occurrence frequently with prolonged standing, and certainly being in crowded or hot environments. And then, of course, the premonitory symptoms of autonomic activation, and that included the pallor and the sweating that we saw in this case as well. So I think management-wise is difficult, but I think the aspects of practice that are important is to be very thorough with your medical history. And I think for many cases for vasovagal, the diagnosis can be made alone just with historical aspects. Education rather than drugs is the cornerstone of treatment. And certainly I try to reassure the patient and not dismiss the condition because of its benign nature. And I'm happy to try drugs, but I'm honest at the outset to say they're of limited proven therapeutic benefit in all patients. Right, have you got any questions about that case before I proceed to the third one?
So I just thought the neurogenic syncopes and the vasovagal were a little different, but you're still saying this.
They're just different names for the same thing.
Yeah, and I don't always find it helpful to have them described in set, clean boxes, because David may talk about this, but many of their mechanisms are common. And so what you call them is one thing, it doesn't always help the patient, and it doesn't always help us to guide treatment either. But it's really trying to understand the mechanisms that are important. But yes, the reflex and the neurocardiogenic and the spectrum along the autonomic dysfunction have very much things in common in terms of mechanism.
What about the role of ventilation?
I do see that. I see that more often as a response rather than a component, or they can certainly be part. Anxiety certainly is of increased propensity in this group of patients, so we can certainly see that in association, but I don't see hyperventilation.
I think hyperventilation is very common at the onset of vasovagal syncope. I mean, I've done hundreds of tilt table tests. I worked as a research guy with a cardiologist who worked tilt table testing in the clinical practice. The patients almost universally hyperventilated at the start of fainting as part of the response.
Oh, sorry, I must have misunderstood your question. I thought hyperventilation you thought as a separate anxiety syndrome. But if you're referring to the increased breathing, yeah, no, that's certainly very, very common. Not often reported by the patient because it's a subconscious thing, but certainly on a tilt table objective test, you can certainly visualise that very clearly.
The chronic overbreathers often report pre-syncopal symptoms anyway.
Yeah.
I'm just wondering whether it just goes that little bit further and they increase the respiratory rate 1 or 2 more respirations per minute.
Yeah.
One of the triggers.
Yeah, it's hard to know if it's always a trigger though, because you can often see an increased heart rate as part of the autonomic dysfunction. So it's hard to tease it all out. So again, trying to label it is not always helpful, but that observation about the autonomic tone representing as a different heart and breathing and blood pressure is certainly important. Sorry, another question.
I just wondered, as well as the salt and water advice, I've always said to young women who have sympathy, I've said, you can increase your caffeine. Is that not such a good advice?
Caffeine initially seems like a good idea, doesn't it? Because it's a common stimulant, it's widely available. But I haven't always given the advice, and the reasons for that are many of these patients will already have autonomic dysfunction, and that can be associated with inappropriate sinus tachycardia, for example. And then the sensation of increased heart rate with caffeine can often confuse the premonitory symptoms, and it's very uncomfortable for the patient. And then, of course, caffeine is good for the initial cup, but then subsequently it's a diuresis, so then you actually lose volume. So there are some things that seem like it's helpful, but for many of my patients who have actually cut down off caffeine have actually had improved quality of life.
So what was the outcome of this case? Did you do any follow-up?
Yeah, she's still a patient of mine now, and the treatment that I think really changed this would be probably termed proven but somewhat experimental in this country. And the drug that changed things around for her was a drug called atomoxetine. And it is used for attention deficit disorder at the moment and is approved for that use. But I have this on special consideration for vasovagal. And it's a postsynaptic uptake inhibitor of noradrenaline. And that's managed to change her response in terms of blood pressure, and she's now working full-time and has had only 1 hospitalization this year and 2 last year, so yeah, quite remarkable.
How many syncopes a month or a week?
Oh, very, very, very few. So what's good about this case now is that this, and it was not what I expected, was not only a reduction in the pre-syncope and the syncope, but there had been a more prolongation of the symptoms, enough for her to recognize those early symptoms and then take an action plan to sit or lie down. All right. But it's not widely available, and I think when I spoke to the Ministry of Health, I think I'm the only person who has this approved for this country. And so I am fielding a number of referrals from my colleagues as to how I got that when they have not been successful. It was atomoxetine. But there was one very good trial, and it was that I submitted to Pharmac to get that approved. So I've got one final case. This one's also very interesting. It's a 32-year-old art history student who has a very sad story of having had lymphoma as a 19-year-old and was currently in full remission, but then unluckily had a pituitary macroadenoma that was non-functioning, but because it became hemorrhagic, required partial pituitary resection. And the symptoms that she presented were lethargy, dizziness episodes, and collapses. And subsequently to pituitary resection, I was asked to see her, and for her pan-hypopituitarism, she was already treated with hydrocortisone, thyroxine, and cabergoline, so quite well-established therapy. And you could easily understand that there'd be multiple mechanisms for her symptoms of dizziness. And these are her typical descriptions of just 3 episodes. I just woke up on the floor, I don't remember how it happened. I just stood up, having been seated at a computer, and felt lightheaded and just passed out. And the one that really got me going was I was just lying in bed. I remember stretching out my arms to turn off the alarm, and then I passed out. And it's a very interesting story. I rechecked her potassium, rechecked her magnesium, and she was adamant she didn't have any palpitations. There was no family history of sudden cardiac death, seizures, deafness, recurrent miscarriage, or drowning. And there may be some hints in my history that you already have a clue as to what the diagnosis is. The examination is pretty unremarkable. So I've got a regular pulse that is consistent with sinus, no signs for heart failure, there were no murmurs, and the blood pressure, although low when supine, didn't really fall after 2 minutes of standing and rechecking again at the interval 1 minute. Her ECG is this, and I hope that is shown at the back, but would anyone like to comment on this ECG? Sorry, wasn't it? It is. It is, and it's not always visible to those at the back, I'm sorry, but it will be magnified. So yes, this is a ECG showing sinus rhythm. It is a normal cardiac axis, and as has been pointed out, the PR interval is top null, but the most marked abnormality there is the QT prolongation, and it's often most easily ascertained and seen in the precordial leads, and I often will see that very obvious in lead V2. So indeed, this was long QT type 2, and although there are many subtypes, this one was relevant to the patient because it is a disorder of myocardial repolarization, results in prolonged QT interval, and importantly, it is a risk for sudden cardiac death because of torsades. And although this case turned out to be congenital, there are multiple acquired causes too. And symptoms in patients can include palpitations, syncope as we've seen, seizures, and a cardiac arrest. Here's a magnified view of the prolonged QT interval, and just a reminder that unlike other intervals, the QT interval is calculated from the onset of the QRS to the end of the T, not the beginning of the T. And the QT interval shouldn't be taken as an absolute. It is corrected for the heart rate. So in the lead that you see the QT prolongation the longest, you should also use that heart rate or in milliseconds to correct for the rate. So corrected, it is the absolute QT interval measured in milliseconds divided by the square root of the RR duration. And for this case it was 1 second, so indeed was 480 milliseconds, which for a female is prolonged 10 milliseconds above what is acceptable. I'm just wary of time, so I'll just keep moving forward. So the diagnostic approach really is the clinical circumstance, and in this case the startle from the alarm clock was the trigger for my history. Took a careful family history, and it wasn't until I did the ECG of the mother that I saw a prolonged QT interval as well. And I've summarized on this slide, that's not meant to be readable, but just at the top left-hand corner is the component that is congenital, and the rest of that slide is all about acquired and can be divided into metabolic causes. There are some bradyarrhythmias, but the large bulk of it is meant to represent the drug therapy. So there's lots of drugs that can prolong the QT. It's important for those who don't even have congenital, let alone those who do, to try to avoid those drugs. And I would just skip this slide to point you to this Credible Meds website, which I find incredibly useful because it's always updated and gives you a very up-to-date list of those drugs that prolong the QT interval. So we've talked a little bit about the pathophysiological mechanisms, and I'm just going to leave that to David. I think my practice points would be to take a very thorough and accurate clinical history. The evaluation should include the types of episodes, number of episodes, the premonitory symptoms, observers and bystander reports, the position and the context in which the syncope occurred, the provoking symptoms, the family history, and of course the injury that is sustained. Of course, as we've seen in our first case, if there is a history of coronary or structural heart disease, that should be a point for prompt evaluation. And likewise, if there's anything that suggests arrhythmic syncope, that David will explore further, either from the clinical aspects or from the ECG, and then the comorbidities if there are severe anemia or electrolyte disturbance. All right, so we have some questions at the end. I'd just like to welcome David.
You've got 5 minutes left, Boris. Right, so we've just got a very limited time left now. I just want to touch on red flags and differential diagnosis. Syncope is within the whole sort of gamut of total loss of consciousness. Boris has talked about the definition of syncope, and there are 3 types of syncope: reflex syncope, syncope due to orthostatic hypotension, and cardiac syncope. The reflex syncopes, or neurally mediated vasovagal syncope, situational syncope like micturition syncope, cough syncope, swallow syncope, post-exertional syncope and carotid sinus syndrome. And then we've got syncope due to orthostatic hypotension, which is relatively common, especially in the elderly, often drug-induced or neurogenic. We have to go very quickly because we've got a very short period of time. And then cardiac syncope, which Boris has touched nicely on, bradycardia and risks of tachycardia as well. And really, the key is the history, physical examination, and then the ECG, and then risk stratification. And does the patient need to go to the hospital? Do they need to be referred to an outpatient clinic? And what are the red flags? And so low-risk patients, those who have a prodrome typical of reflex syncope, lightheadedness, warmth, sweating, nausea and vomiting, after some sort of noxious stimuli, although of course that can happen with long QT, as Boris has just said, triggered by typical situations. Whereas in the history, red flags are things like chest pain, nude chest pain. Chest pain and syncope is a red flag. That could be an acute coronary syndrome and ventricular arrhythmia. It could be a pulmonary embolus. It could be an aortic dissection. So chest pain and syncope is something to worry about, and that really warrants immediate referral. Palpitations with syncope. So palpitations with syncope is relatively specific to the likelihood of an arrhythmia, although it's quite common to get sinus tachycardia with vasovagal or vasodepressor syncope, and so quite often you get palpitations with sinus tachycardia as well. But with an arrhythmia, it's a very abrupt onset, and people can get syncope with SVT. It's always right at the start of the arrhythmia. Usually the blood pressure will come up, so it's right at the onset of the palpitations that it's likely that you'll have syncope if it's due to an arrhythmia. In terms of the past medical history, if you've got a long history of syncope, it's usually going to be benign, and it's most often vasovagal. Red flag for syncope is the first case is structural heart disease. And then major red flags on examination are things like GI bleeding. When I was a fellow in Chicago, God forbid, I saw the professor of obstetrics who came to the clinic because of syncope, and it transpires the cause was a GI bleed, and how he didn't sort that out himself, I've got no idea. And then the red flags with the ECG, and I had quite a few red flag ECGs to go through, but we just don't have time. But the most common syncope that we all see is vasovagal syncope, and I had quite a few ECGs to show, but we don't have time. But this is the first description of vasovagal syncope by Sir Thomas Lewis in the BMJ in 1932. And this is a beautiful description of vasovagal syncope, and perhaps just read through that. And there's nothing better for the diagnosis of vasovagal syncope than the history. Tilt table test is not as sensitive or specific as a good history. And so the history is paramount, clinical examination, an ECG for everyone, and then red flags. Any questions? I'm sorry, we're actually at the end of time now, and so